Over 65, the golden years. A time when wisdom gained through a lifetime culminates in fulfillment and joyous living. Here on the La Jolla campus of the UCSD School of Medicine, the Sam and Rose Stein Institute for Research on Aging works to solve medical problems related to aging, so people may be free to enjoy lifelong health and independence. The Institute sponsors a monthly lecture series, which you are about to see.
I'd like to begin with a few thank yous, and first of all, I'd like to thank Dr. Segmiller and the Stein Institute for Research on Aging for providing me with this opportunity to speak to you. I'd also like to thank my mentor and the head of the Division of Geriatric Psychiatry here at UCSD, Dr. Dept. He's been a big supporter of my career and also was a supporter of my development of this talk. I'd also like to thank the authors of this manual, which allowed me to get started in this area, and it was written by Edna Ballard and Cornelia Poor, who are members of clinical faculty at Duke University, and the title of this is Sexuality and the Alzheimer's Patient, and this is a pamphlet that's available through the local Alzheimer's Association. Lastly, I'd like to thank Stuart Hines, who did his geriatric psychiatry fellowship here at UCSD a few years ago and was a major help in doing the scientific literature review, which helped us develop this talk. Now, a few years ago, I never would have dreamed that I was going to be standing in front of a group of people talking about sex. But I must tell you what happened is that I have been in the community here and giving talks on various topics pertinent to seniors and pertinent to the field of psychiatry. And over the years, on several occasions, I have had family members as well as professional staff approach me and ask me questions about sexuality, and in particular about sexual issues when a member of a family has been afflicted with dementia. And it was because of those questions that I received from people in the community that I thought, well, maybe there is a niche here that has not yet been filled, and that then provided the impetus for Dr. Hines and I to develop this talk. Now, probably because of my anxiety, and perhaps you're not anxious, but talking about sex is still something that I'm getting comfortable with in a public forum. I've included a number of cartoons as we go along, and I think they're mostly to help me laugh a little bit and not be too anxious. I hope you all laugh a little bit as well. Most of the cartoons do focus on issues related to relationships. Now, we're going to be covering a number of fairly broad topics, and I really don't intend to make this particularly detailed, but it's meant to be a survey, and it's meant to provide all of you with a stepping place where you can step off and begin further consideration and reflection on these issues. Much of what I say tonight will be somewhat philosophical, because in this arena I have found that there isn't any one correct approach or answer to some of the problems that you'll be hearing about. This is my first cartoon. It's actually just kind of a general cartoon that psychiatrists would laugh at. What you see here is a young girl, and perhaps it's her father or her grandfather who's told her a story. And the father is saying to the little girl, "And they lived happily ever after." And the little girl pauses for a moment, and then she turns to her dad and says, "Were they on Prozac?" Just to put things in perspective, I think it's important for us to remember that sex is one of what we call the primary drives, and this slide lists all four of what are considered to be the primary drives: thirst, hunger, the avoidance of pain, and sex. This slide just gives us a feeling for how important it is going to be for us to become comfortable talking about sexual issues and physical intimacy among older people, because as you all know, I'm sure, our population is aging. And what you can see depicted here is that in the year 2000, there were approximately 35 million people here in the U.S. who were 65 years or older. And as you can tell from the upward direction of the graph, that number is going to increase more and more. So I think we're going to be hearing more and more about a lot of issues pertinent to elderly and older individuals, including physical intimacy. Now, one of the things that I do my best to combat as a geriatric psychiatrist is something that we call ageism. Ageism is a term to describe really inaccurate ideas about what it's like to be an older person. And some of these inaccurate ideas about being older have to do with sexual behavior. Here are some of the myths that you all may be familiar with. Some people believe that older people are not interested in sex. What do you think of that? It's a myth, huh? Yeah, okay, enough said, here you are. Some people believe that older people wouldn't benefit from sex education. Some people believe that people who are ill or who may be dying will have no interest in sex and actually should be protected from sexual activity. Well, the good news is I think the word is getting out. And what you see here is an article from my hometown newspaper, Des Moines, Iowa. This was an article that appeared about 1 year ago. And I was delighted to see that even in my hometown, people are beginning to understand that it's never too late for love. And here you see an older couple, and they were both widowed and met and fell in love. And what you see now in this photograph is a scene from their wedding. Well, perhaps these things don't need to be stated explicitly, but you know, there are a lot of really important reasons for older people to have sex. For one, it's really just the continuation of an inherent biological drive that doesn't just magically disappear as we get older. Also, experts in the field of sexual behavior point out that older people may have something to teach younger people about sexual behavior, and that they may serve as role models for individuals who are younger and in relationship. Another important reason for sex in older people is that it helps us strengthen our identity, that we are, among other things, sexual beings, and it's nice at any age to be validated in terms of your sexual desirability or your sexual attractiveness. You know, sex is also good for maintaining physical conditioning. What do you think of that? It may also help individuals afflicted with arthritis in terms of keeping their joints flexible. And also, as at any age, we know that sexual experiences can be a nice way to help alleviate psychological stress. Well, in order to kind of get away from some of the ageism and perhaps some of the inaccurate cultural influences here in Western civilization, Dr. Hines and I spent some time looking into the scientific literature that was based on sexual behavior in what we would call traditional societies, non-Western cultures. And we found a very nice review article that looked at 106 different cultures, and what they found was that 70% reported sexual activities in males of very old age, sometimes beyond the age of 100. So in these traditional cultures, we see that older men are remaining sexually active. They also found that 84% reported that sexual activity and interest was observed in women who were older. So when we stood back and kind of tried to understand what this cultural data might have told us, we saw that these studies were really telling us that in traditional cultures, sex is really viewed fairly neutrally, and that's somewhat different than many of us who have been raised here in the United States. We also saw that sexual interest remained high, and it seemed in some studies to be particularly high in women, and there was discussion about how in traditional cultures, as women are freed from responsibilities of childbirth and child rearing, that these cultures granted women some additional permissiveness in terms of the flamboyancy of their dress, and also in terms of things like the amount of exposure of their bodies that was felt to be acceptable or proper. Another interesting thing that we observed from these studies was that it wasn't uncommon for there to be sexual liaisons between older individuals with younger individuals. And of course, that's something that our culture has pretty strong feelings about sometimes, and certainly often is not viewed so neutrally. What you see here is a couple of robots that is, and they've gone to see a therapist. And after some contemplation, the therapist has turned to this couple and says, "The problem, as I see it, is that you both are extremely adept at pushing each other's buttons." Okay. Now I'd like to shift gears and talk about some research that was actually done here in the United States, and the research was done looking at what were defined as healthy older people. And we actually found 4 different studies, all fairly recently done. The oldest of these 4 was published in 1988, a couple from 1998, and one from 1999. And the focus of these studies was to look at what was happening with older men and women in terms of their sexual interest and their sexual behavior. What we found when we looked at these studies is that there was a general decline in sexual activity and sexual function, but there was no reported decline in satisfaction from sex. And I think that's a very important part. Although we know that there are physical changes associated with aging, what isn't changing is that sex remains satisfying throughout the adult lifespan. We also knew from these studies that the maintenance of sexual satisfaction in men seemed to depend on both their overall fitness, so that men who felt healthier actually would report higher levels of sexual satisfaction, and also we found that men who felt that their partners were attractive reported a higher degree of sexual satisfaction. In women, things were a little bit different, and I don't think anyone may be surprised by this, but what we found in terms of maintaining sexual satisfaction in older women, some of the things that were important were, number one, continued participation. It was observed that women who had gone for a long time without physical intimacy were less likely to have additional physical intimacy and less likely to report that as satisfying. Another important thing that we learned from these studies was that for a woman to report a sexually satisfying experience, there had to be a sense of connection or emotional intimacy present in order for the woman to feel that that experience really was satisfying. Now I'm going to switch gears a little bit. We've talked about sexual behavior in traditional societies. We've talked a little bit about sexual behavior in healthy older people in the United States. What I want to talk about now, and perhaps the most important part of my talk, is really talking about the effect that the diagnosis of dementia has on the sexual life of a person, as well as the impact that that diagnosis might have on family members, especially their spouse, and also what happens when a person with dementia moves into some type of residential facility. How does that affect that person's ability to have a sexually satisfying life? Well, what you see here is a photograph taken from the San Diego newspaper, and this also came out about a year ago. And the two individuals that you see here in the photograph are both residents of a local residential care facility that takes care of people with dementia. And these two individuals, both of whom have dementia, fell in love. Well, this was the kind of situation that made a lot of the professional care providers very anxious, because they weren't sure what was the ethical and appropriate way to respond to this situation. And it was a few of them who came to me and said, "Dr. Sewell, tell us what to do. Is this okay? How do we sort this out?" Well, hopefully, by the end of my talk, I'll have given you all some ideas about perhaps how we might sort out this type of situation. Here you see a couple in a restaurant, and they're obviously in love, and the gentleman's presenting a ring to the woman, and he's saying, "We're made for each other. I don't like your mom, you don't like mine." I kind of would like to revise this. If I were a cartoonist, I might have said, I might have made these two people older looking, and I might have had them saying, "We're made for each other. I don't like your kids, and you don't like mine." Well, just to make sure that we all have a common understanding of what dementia is, I've included a slide that gives a definition. Dementia is an acquired syndrome of decline in memory and at least one other cognitive function. For instance, the ability to, the lack of the ability to name something, perhaps the inability to recognize familiar faces, or perhaps the inability to recognize how to use common objects, or perhaps some other cognitive function. And the losses or the changes have to be sufficient to affect daily life. Now, Alzheimer's disease, or what you see here abbreviated AD, is the most common cause of dementia. And depending on what expert you want to refer to, it's been estimated that about 66% or so of all older individuals who have dementia of the Alzheimer's type. The second most common cause of dementia is vascular dementia, or what is sometimes referred to as multi-infarct dementia. And we know that about 20% of patients with dementia may actually have both Alzheimer's and vascular dementia together. Now, there are other less common causes of dementia, and I've listed some of these here. They appear mostly on the right-hand column here. Dementia can occur in association with Parkinson's disease, in association with heavy and continuous alcohol use. Trauma to the brain can lead to dementia, and so on. But regardless of the cause of dementia, dementia can affect various regions of the brain and then lead to losses in function. Now, to kind of set the stage then, I'd like to say that one of the things that many of us in this field really put a premium on when we're working both with patients and family members of patients who have dementia is on the maintenance of the quality of life. And here is a quote from the book that I showed you earlier that says, "In the absence of a cure, the most significant thing we can do is adapt our approaches with each change in symptoms to make life as meaningful and satisfying as possible." And I think that's really why I'm concerned about this issue, is because I think that it's unavoidable that having a good quality of life is more than just good sleep. It's more than just good food. It's actually also, to some extent, being aware of the importance of physical intimacy in whatever form that might take. Well, it can be very difficult to find a way to meet the sexual needs or the physical intimacy needs of a patient who has dementia. They are experiencing both physical and cognitive changes. Their bodies may be impacted by the effects of medications. There may be all sorts of emotional changes, both in terms of the patient as well as the patient's spouse. And also they may have changes in their environment. For instance, perhaps the most dramatic change would be moving to a residential care facility where suddenly they basically have lost most or all of their privacy. Well, in addition, it's often the case that some behaviors that others might interpret as sexual may not really be sexual behaviors. A person with dementia who's touching their genitals really may not be indicating any type of sexual desire. It may be something like a way to communicate that they need to use the bathroom. In addition, if a patient with dementia crawls into bed with another patient, it may not be that they're being sexual predators. It may simply be that they really are seeking comfort, companionship, or protection. So we really have to be careful when we view a person with dementia and not jump to conclusions and misinterpret what their behaviors may mean. An individual with dementia is prone to misinterpret the behavior of others. Not only may we misinterpret them, they may misinterpret us. For example, innocently, a professional caregiver may enter the room of a patient with dementia and say, "Hi, handsome, how's my boyfriend today?" Well, if we were cognitively intact, we would put that in context and recognize that as an attempt by the caregiver to be friendly. But if we have cognitive losses that are interfering with our ability to accurately interpret information, suddenly that what was intended to be an innocent comment may be interpreted as a pretty dramatic come on. So we have to be very careful in terms of the language that we use because, again, we who are cognitively intact may be misinterpreted. The good news, I think, for many of us, particularly those of us who are in the role of professional caregiver, is that inappropriate sexual behaviors among patients with dementia are actually uncommon. They're actually quite rare. Now, how does one deal with inappropriate sexual behaviors? I think the most important thing is to try and understand the reason for the behavior. And it's important that we recognize that physical contact remains important, even if it may not be sexual. Sometimes just making sure that a person is touched is an important way to help them and may actually lead them not to behave in a sexually inappropriate way. We've found that just ignoring inappropriate sexual behavior doesn't make the situation any better. We think it's important that we actually be proactive and that we provide attention, affection, and contact and perhaps really head off the development of inappropriate behaviors. It's also important that when a sexual behavior occurs, that the individuals in the environment remain calm, because we really want to avoid unintentionally rewarding or encouraging the behavior. We also know that it's important when some patient with dementia displays an inappropriate behavior not to scold them or to shame them. We know that those types of strong emotions could precipitate what some experts have termed a catastrophic reaction, where the person feels so emotionally distressed that even more problematic behaviors may appear. Sometimes you can use distraction, and you can just change the subject or change the activity, and the inappropriate behavior may go away. If you try some of those things and the inappropriate behavior persists, it's probably reasonable to consult a physician, because sometimes the persistence of an inappropriate sexual behavior can be the sign of an undiagnosed medical problem. For instance, a patient might have developed a urinary tract infection, and it may be that the reason that they're constantly touching their genitals is simply because they feel pain or discomfort from that region of their body. Sometimes inappropriate sexual behavior can be the sign of a psychiatric illness, such as a patient who develops a syndrome called mania, which includes the possibility of an increase in libido or what we call hypersexuality. Another reason that you might want to consult a physician is that the physician may have some helpful things to offer. There may be medications that can be provided that will help alleviate the problem behavior. It's also important to consider that if there isn't an illness, and if it's just that this person does have libido and does have an urge to seek sexual gratification, it may be that just providing that person with privacy is all that's really necessary. So you might allow that person to have some time alone in his room or her room, and that in and of itself may alleviate the problem. Here are a couple of people dining. I assume that they're probably man and wife. And the woman is saying to her husband, "No, I don't want you to change, Daryl, but sure, it would be great if you were completely different." We know that when a member of a marriage or a member of a couple develops dementia, the impact on the spouse or the significant other can be quite significant. In some cases, the spouse becomes paralyzed by grief. Some spouses will just begin to deny that that's a part of their life anymore, and they'll just shut off that part of themselves and pretend as if they don't have sexual needs. Some spouses will just decide that their needs aren't as important, and that thereby they'll just not attempt to have any of those needs met. In other cases, a spouse will really begin to see their spouse with dementia as a different person, and that person may slowly be changing so that they end up becoming someone that the spouse doesn't even really recognize anymore and really isn't able to connect with in any type of significant emotional or cognitive way. And we know from the research I presented earlier that for women that would be especially problematic, because we know that many women really do need that sense of connection in order to have a satisfying sexual experience. On the other hand, some couples do manage to continue a very warm and satisfying sexual relationship in spite of the dementia. So I think it's important that we recognize that there's a whole spectrum of potential outcomes. We know that a spouse has the right not to be abused or to participate in an activity that is no longer satisfying or is upsetting or frightening. And I think this is a really important message that we need to deliver, because I think that a person who's caring for a patient with dementia can be under tremendous stress, and their thinking may be clouded, and their devotion levels may be extremely high, and somehow all of those factors might collude to lead them to make a decision that really isn't in their best interests. And so I think it's important that we let spouses of patients with dementia know it's okay if the sexual experience is frightening or if it doesn't really provide them with any satisfaction. It really is okay for them to say no. We know that to give and receive affection, physical intimacy, or caring for another are needs that do not die, even with the overwhelming responsibilities of being a caregiver. I want to shift gears a little bit and talk about what can a caregiver, a spouse, do when their partner has dementia. Well, we know that there are a lot of issues, and that if there are adult children in the picture, the adult children may have strong feelings about what's happening with their mom and dad. And they may feel very strongly that it's inappropriate for the spouse to have any type of experience outside of the relationship with their other parent. And this can kind of put the healthy spouse in a bind because it may make them feel like certain options may not be available to them. And I think that what I've come to realize is that each person really needs to sort this out for themselves, and that there isn't just one right answer for any given couple. Now, what you see here are a couple of people at a cocktail party, and the gentleman is saying to the woman, "Oh, I've had a few failures," followed by a string of successful marriages. That's a pretty clever way of saying something. But I think what I'm getting at here is perhaps one of the most controversial parts of this area, which is I think that because the illness dementia can span 10, 15, 20 years, I think many healthy spouses get to a point where they really begin to think that perhaps there are solutions for them that may involve seeking physical intimacy with someone other than their husband or wife. And I think that's a really controversial thing. I think that it depends a lot on a person's value system, perhaps on their religious beliefs. But short of that, there are other possibilities that I think we need to be comfortable with. And even if having physical intimacy with another person doesn't feel right, then I think we need to be comfortable with the idea that a healthy spouse is entitled to do things like have opportunities to masturbate. The last area that I'm going to touch on is what happens when a patient with dementia moves into a nursing home. I think that really introduces a whole new slew of factors, because now suddenly this person is in a more public environment. And not only that, they have now been placed in custodial care. And so the professional caregivers have a really large kind of sense of responsibility and desire to do what's not only ethical, but also what would be a healthy thing for the patient. So we know that sexual behavior in nursing homes differs in significant ways from such behaviors at home. We know that in the nursing home, sexual behavior is no longer a private matter, but in one way or another has an impact on staff, other residents, and the families of residents. Well, so what is the responsibility of a caregiver in a residential facility? I think the first thing is the caregiver needs to assess the behavior, and I think they need to approach the situation with the thought that there is some type of valid need that needs to be met. It may be, as I said, that the person is communicating the need for medical treatment. It may be that the person is communicating the need not necessarily for a sexual experience, but for a hug or for an opportunity for just physical contact. Or perhaps the person is actually indicating a need for a sexual experience. I think once we have a sense of what that need is, then we need to find a way that helps that need be met effectively, appropriately, and in a dignified way. There are some common problems that I've heard about when I'm in the community in terms of problem behaviors of a sexual nature. in the nursing home. And one problem that we see is that a person may misidentify another resident as that person's spouse and may even initiate intimate behaviors. And if that happens, some of the suggestions that I recommend are gentle reminders that the person is mistaken. But again, I think it's important not to argue, scold, or shame, because that can often make the situation worse by precipitating a catastrophic reaction. I think you can use distraction. You can change the subject. Let's go for a walk. Or you can change the topic of conversation. Boy, that shirt looks good on you. And those kinds of things often provide a quick and effective resolution of the problem. If a person persistently identifies someone inaccurately as their spouse, in larger facilities, one intervention that's been proven helpful is actually relocating the two people so that they're farther apart, perhaps putting one patient in one wing and then moving the other individual to another wing. And sometimes that geography alleviates the problem. Another problem that we see in residential facilities is that a resident may undress. And of course, that can cause a lot of difficulty. It can embarrass staff, it can embarrass the other residents, and certainly if the family is present, they may also be embarrassed. So there are certain things we can recommend. For instance, we can recommend that women wear slacks instead of dresses. We might help a gentleman get dressed but place his belt buckle behind him so that it's less easy for him to access that. Or there may be certain types of fasteners that can be used that are less easily undone. This is kind of a tricky thing, though, because if an older person with dementia is experiencing any type of problem with urgency, the need to use the bathroom kind of quickly and unexpectedly, sometimes we regret if we've used these types of interventions. Another problem that we see in residential facilities is that a resident may masturbate. They may masturbate with a harmful object. In that instance, of course, if there's any sign of trauma, a physician needs to be consulted. We need to think about what may be responsible for the behavior. Is the person simply being neglected and not engaged in some of the activities that are possible? Perhaps the behavior is a function of boredom. Sometimes when a male resident is being assisted with bathing or other activities of daily living, this may result in the resident misinterpreting and perhaps exposing himself or doing other inappropriate behaviors. And in this instance, there are things that we have found to be helpful, including using a staff person whose gender is not one in which the patient is attracted to. It may be helpful to have more than one person present. It may be helpful to increase the clinical environment so that it's a less cozy environment and there are visual cues that this is actually a clinical environment, such as having the care providers wear uniforms or gloves. It's important that we, both whether we're professional caregivers or family members, it's important that we look at our own attitudes and beliefs and look at how those may be affecting our reactions and the choices that we make. It's important that we remember that individuals who are competent and rational have a right to act within their belief system. It's important that we realize that we don't have to change our beliefs just because the beliefs of the people around us may be different. Here's another couple, and they're professing their affection for one another, and the gentleman is saying, "Love comes and goes, Janet, but this is true codependency." Well, how do we decide whether it's appropriate to allow sexual contact between two individuals, both of whom have Alzheimer's dementia or some other form of dementia? I think what we've seen in the literature, what little bit of information that there is is the key concept really is informed consent. And there are different aspects of the informed consent process, but informed consent involves the notion that the participation is voluntary, that to some extent the person can understand what it is that's about to happen, and we call that mental competence. And they have to also be aware of the risks and the benefits. It's important that there be no physical or psychological coercion. It's important that when we're thinking about this idea of competency, that I think it's important that we apply a more narrow definition and that we recognize that there are many different types of competency. The competency to enter into a legal contract may be different than the competency to decide on whether it's appropriate to have physical intimacy. Nonetheless, I think that if physical intimacy is going to be permitted between two individuals with cognitive impairment, they should at least have some general understanding of the risks and the benefits. Even if their understanding is stated in a somewhat simplistic way. For instance, if they can say, I want this because it makes me feel good, that would be important. They also need to know, though, that there could be risks involved. For instance, that the experience may be very time limited, that the person that they're choosing to be close to may move to a different facility or in some other way be separated from them. So I think we would like to think that they know to some extent both what the good and the bad could be from the experience. Now, you know, this is a question that was raised in an individual that Ballard and Poor worked with back in the Duke University area. And one of their husbands of a patient with dementia turned to them and said, is it rape if she's compliant but does not understand? And I think keeping in mind those criteria that we just spoke about, their answer was, if the individual enjoys or initiates the behavior, and if the behavior is mutually satisfying to both, then it really isn't rape, and it's probably okay. Now, we actually found in the literature some published criteria that were developed back in Virginia. And these criteria were developed by a couple of clinicians working on an inpatient unit taking care of patients with dementia. And they actually broke their criteria into 3 parts, similar to what we just spoke about in terms of informed consent. They said, first of all, that the patient has to have an awareness of the relationship. And it's important that they don't believe that the person is their spouse. If that's their false belief, then it's probably not appropriate for them to be allowed to be intimate with one another. It's also important that there be no exploitation whatsoever. So we try and put things in context and decide, perhaps based on input from close family members, is this behavior consistent with the beliefs that this person held prior to the onset of their illness? It's also important that we try and discern whether or not the person has the ability to say no. And we know, for instance, that in certain dementias, particularly dementias that might affect the frontal lobes and affect things like judgment and executive functioning, the ability to discern right from wrong, if that's the case, then the person really may not have the ability to say no, and then perhaps, and in that case, we would not feel comfortable allowing the physical intimacy to occur. Again, Lichtenberg and Strzepek also talked about the importance that the patient have awareness of the potential risks involved. Do they realize the relationship is time limited? And can they talk about what they would feel if the relationship ended? How would that be? How would they cope with that? We actually only have found just one study that was done scientifically that looked at sexual behavior in patients with dementia. And this study was conducted by a group of researchers headed up by Dr. Zeiss. And she looked at 55 male Alzheimer's patients, and they evaluated their sexual behavior. They found that in 52% of these men, around the time of the onset of the Alzheimer's disease, these men developed erectile dysfunction. They also noticed that there wasn't really any clear pattern in terms of cognitive decline and change in libido. They noted that some men who experienced dementia were having an increase in their sexual interest, whereas other men were experiencing a decrease. They also noted that in most instances, the caregiver or the spouse's sexual interest declined. And again, I think that speaks to the fact that unfortunately, dementia can often affect personality and grooming and many other things that would transform a person who was formerly very attractive and desirable into someone who is no longer that way. Inappropriate sexual behaviors in patients with Alzheimer's disease are rare. There is one form of dementia that seems to be somewhat more likely to be associated with inappropriate sexual behavior, and that form of dementia is frontal lobe dementia. Okay, so I'm going to kind of use these last three cartoons to sum up, and then I'm going to hopefully have some time for your questions. This cartoon shows Frosty the Snowman. He's gone to a plastic surgeon, and the surgeon is saying, this is a very popular choice, the weenie. And if you can see, the card the doctor's holding up is a hot dog. And the caption reads, Frosty gets a nose job. I think the main point of, the reason I put this cartoon here is because it reminds me to emphasize that I think what we know from both studies in traditional cultures, studies here in the United States, we know that having a quality physical intimacy experience is important throughout the adult lifespan, that doesn't go away in spite of some of the myths and the ageism that we have in our culture. What you see here are two dogs on a porch. They look pretty old, and there's a cat that's a male person here with a mail bag, and one of the dogs says to the other dog, "We're getting old, Jake." Not a cat nor a mailman can get them excited. I think the point of this cartoon really is to acknowledge that there are changes, physical changes that occur as we get older, and those physical changes can affect how we go about having physical intimacy. We may end up experimenting with different positions. We may find that it takes longer for men to actually achieve erection. We may find that they need more manual stimulation in order to achieve erection. A woman may need to begin using some form of lubrication. But the bottom line is that in spite of these physical changes, what we know is that sexual contact remains satisfying and that there really isn't a loss in that aspect of sexual behavior. This cartoon is my cue. You see here two guys sitting on a park bench, and one of them says to the other, "Been there, but I can't remember if I've done that." This is my cartoon to remind me to say to you that even when a person develops a cognitive disorder or a form of dementia, we still need to be sensitive to the fact that they may have sexual needs. And in fact, we need to be sensitive to the fact that their spouse may have sexual needs. And although it's awkward and difficult to talk about these things, they are important. And I think my hope is that through discussions like this, we as a culture will begin to become more comfortable looking at these issues and allowing those around us to come up with solutions that are acceptable. And I think that it really is important that we have a level of comfort, because even if this isn't an issue that's touching your life directly, who knows? You may have a friend, you may have a relative, you may have a neighbor who really is quite distressed about these issues, and you may be able to serve a very important function by providing them a context or an opportunity in which to talk about their feelings and to work it through. In sum, then, I want to say that there isn't really one answer appropriate for any person, that each person on their own has to decide what makes sense for them, but perhaps we can be a part of their journey in helping sort out what is correct and what is right for them. This is my last cartoon, and it's one of my favorites because, of course, as a psychiatrist, I get ribbed a lot about the couch and about making recommendations. What you see here is a psychiatrist with his patient on the couch, and the patient is saying in quite a distressed way, "That's it? That's your advice? If I'm happy and I know it, clap my hands?" I'd get a new psychiatrist. Well, I thank you very much for your attention, and I think we do have perhaps a few minutes for your questions, if there are any. The question is there any scientific evidence that supports the idea that physical exercise can help delay, slow down, or perhaps prevent dementia, particularly vascular dementias? Is that correct? And the answer is yes. In fact, we know that there is a really strong correlation, and that folks who are more physically fit are less likely to develop problems with vascular dementia. And even if they have dementia, there's a correlation between physical fitness and the impact that the dementia has on that person's life. Yes, you're thinking about sexually transmitted diseases. Yes. Well, you know, actually, one of the things I can say right off the bat is that particularly for those of you who are older and single and may be interested in being in relationship, it's very important that you take safeguards. And we want to be very much aware of the risk of HIV, and we want to recommend that all people of all ages take steps to prevent the spread of that particular disease by using condoms. But it's also important to get to know your partner ahead of time, and I think the more familiar you are with them, the less likely that you may be exposed to some form of sexually transmitted disease. I think it's very appropriate that you be very direct with a partner and that you ask them, do you have any diseases that I should be aware of? I think it's also important that if you're going to have a sexual experience with someone for the first time, that it really needs to be done in a safe way, which would include the fact that the room that you're in be well illuminated so that you both can actually reassure one another by examining each other, because obviously if your partner has some type of wound or ulcer in a region like their genitalia, that's a tip-off that you need to be careful. A few years ago, our Surgeon General at that time, Jocelyn Elders, spoke openly in a public way about masturbation, and her comments stirred up a lot of controversy, and she received a lot of criticism for it. And how does that jive with the fact that now in residential care facilities for patients with dementia, we may be seeing patients masturbate? Well, what I can say to you is that I think Jocelyn Elders was probably a few steps ahead of her time. I think what she said was accurate and valid, but what I think the reaction showed me was that our culture isn't quite yet ready to get comfortable with these types of issues. I don't think that means we should ignore them, and I don't think that we should give up, but I think that's why situations like this are so helpful, and why I'm so grateful that so many people came tonight to listen to me, because I think it shows that we are maturing and getting more comfortable with this issue. And again, as you may recall from one of my first slides, it's just a basic human drive. Just like we get hungry, we also have libido that leads us to seek out sexual gratification. And we don't necessarily have to put a value judgment on that. That's just a part of the biology of being a human being. And I hope that with education, that type of criticism will gradually become a thing of the past.
Yes.
I asked a question about hormone replacement therapy just at the wrong moment. Could you deal with that, please?
I'd be happy to. Thank you for bringing us back to that. Definitely, hormone replacement therapy may have an important role in maintaining the quality of your sexual life as you get older. For example, in women who are postmenopausal, it may be that by taking Premarin or some other form of estrogen, they find that they have a better sexual response. For instance, they may find that vaginal lubrication is less of an issue. So it's certainly worth discussing that with your physician if you think that it's something that you might benefit from.
I just wondered if it were an issue with patients that have dementia.
You know,
Medicated or not medicated?
right. In my experience, we really have not been using hormone replacement therapy in patients with dementia. And I can't tell you exactly why that is. It just hasn't been happening. I imagine it may be in part because of the fear that the risks may be greater than the potential benefits. And of course, some of the risks we see with hormone replacement therapy in women would be an increased risk of things like blood clots and forms of cancer. In men, similar issues can be a factor. Maybe this is a good start.
Well, if there are no more questions, we want to thank our speaker tonight.
This program has been brought to you by the Sam and Rose Stein Institute for Research on Aging. The Stein Institute publishes a newsletter and provides pamphlets on advances in geriatric medicine. Support from people like you, people who believe in healthy and independent aging, makes the programs of the Institute possible. You can help by becoming a member of the Institute or a patron of research. For additional information about the Sam and Rose Stein Institute for Research on Aging, call 534-6299.